Can start recording. All right, okay. Well, welcome everybody. Happy nearly end of the summer, which I can't really believe. We're prepping for the new year and the new semester. We're excited that you are all here. My name's Daniela Friedman. I co-chair the CPCRN Scholars Work Group with Dr. Conn at Emory University. And I'm the site PI here for our CPCRN in South Carolina. We are really excited to have so many of our CPCRN scholars and mentors and colleagues and partners with us today, which is really exciting. And we have a full, exciting program for you. This is a really special group, our inaugural group of CPCRN scholars, and I can't believe the year, our shortened year, is coming to an end later in September, but I know we're all going to keep in touch and hopefully continue working together. So I want to start by introducing our moderator for today, and then he's going to kick off the program. We're really excited to have Randy Schwartz with us. He has done several incredible things, and I know we only have an hour, so I'm going to read just a few of these wonderful things and expertise of Randy. Randy is a public health consultant serving as president of Public Health Systems Consultants, Inc., and he has worked with several national state level organizations. He's senior public health consultant for cancer control with the National Association of Chronic Disease Directors, and we love acronyms, so we refer to that as NACDD. Randy is also adjunct faculty for public health programs, including UNC Chapel Hill School of Public Health. And Randy has had extensive expertise with everything cancer prevention and control related and tobacco control, among many other topics. Prior to Randy's role at NACDD, he served as Senior Vice President of Health Systems at the American Cancer Society, National Cancer Control Department. Before ACS, he was also director of the Division of Community and Family Health of the Maine Bureau of Health, which is now the Maine CDC, where he worked for several years and was in a senior position as division director. What's also exciting to us is that he is a partner and affiliate with our CPCRN and has really provided incredible input into the Scholars Work Group and the Scholars Program. So with that, I am thrilled to turn it over to Randy Schwartz, our moderator for today. He's going to briefly set the stage for our topic and introduce our panelists, and I'm really excited that you're all here. So Randy, thank you so much, and take it away.
All right, great. Thank you. We're really happy to have this practitioner-focused session. And one of the things that we will really look at is this real valuable and important engagement between practitioners, researchers, and the community engagement in advancing implementation science, particularly as we look at implementation science and practice. As Daniela said, I'll just set the stage here. And we have two great speakers, colleagues that I interact with all the time that have a lot of excellent practical experience and do a great job of doing exactly what I just said, linking practice and research and practitioner community and researcher engagement. So, just a few of these definitional items, and I picked these because of the way they're framed. Study of methods to promote the adoption and integration of evidence-based practices, interventions, and policies into routine healthcare and public health settings to improve the impact on population health. So we're doing this for a reason, right? And implementation science also examines how evidence-based programs work in the real world. By using implementation science and implementation strategies, you can help bridge the divide between research and practice and bring programs that work to communities in need. Again, our real goal here, right? And the essential players, as I said here, is, and hopefully we're all looking at this as the framing, researchers, practitioners, and engaged community stakeholders. And a famous quote by a colleague of many of us: if we want more evidence-based practice, we need more practice-based evidence. That Larry Green, who is the kind of father to much of health promotion, disease prevention over the last several decades. Many of us who have a long history in health promotion, health education, have worked with Larry over the years. But this is quoted over and over again. It's not a one-way street. It's not translation to the community, right? We're doing things together. We're not researcher to practitioner. It's how do we do this all together, and how do we have practice-informed research? Well, as practitioners, and that's my role, and I certainly always like to talk about and advocate for this linkage here that I talked about, this three-legged stool. But we're in a good place. We have the community guide, provides much evidence. We have, well, it's there now, Research RTIPS. It's actually now a new site. Evidence-based public health programs from NCI, the CDC's violence prevention program has, as you see, using essential elements to select, adapt, and evaluate. The book from Ross Brownson and colleagues, many other resources. We're in a good place as a practitioner, and we also have these partnerships, right? The CPCRN works with practice settings. We have the prevention research centers, and now we have the NCI-funded ISC3 centers. So, and that's just, a few. There's also NHLBI, National Heart Lung Blood Institute, has an implementation science group. Many of the universities, there's a journal, implementation science. So as people working in the field and as practitioners, we're in a good place to be able to utilize this work to improve practice. And we have an expanding world of players, the Center for Implementation out of Canada, the Consortium for Implementation Science, hosted out of UNC, and there's others. Opportunities to get engaged, practitioners and researchers, right? You have the annual conference on the science of dissemination and implementation health. That's put on by Academy Health with NCI, AHRQ, and many other NIH folks. You have the Consortium for Cancer Control Implementation Science, which is hosted by NCI and includes these new centers, but others, everyone can get involved. You have, this interactive systems framework. SAMHSA uses that quite a bit, and NCI a couple of years ago published Implementation Science at a Glance. So you're probably aware of many of these items, but they provide a good background and framework for the practice world. And so where do we go from here? We need education and training in the academic programs. We need continuing education and professional development, just like the Scholars Program. At UNC and other places, they've introduced implementation science into the MPH curriculum. We have the Consortium, CCIS, and the funded centers at this ISC3. We also have had for a while the Prevention Research Centers is a number of years old, probably 30 years old. The national centers from the Injury Center, the Injury Center Resource Centers that are funded. The CDC platforms has always had practitioner engagement. We're in a great place, as I said, to advance practical, pragmatic evaluation approaches, and also integrating quality improvement strategies into intervention implementation. That's really taken hold. And again, kudos to IS at a Glance. Great document, really gets to the practitioner role. We have intentional linkages in academic health departments, which really look to link local and state health departments with academic public health programs. There's now journals, Sophie's Health Promotion Practice, the IS journal, and there's key competencies on implementation science that we can put into practice. And I thought this was kind of heading to the closing here of my points. A great point by Alice Ammerman from UNC, and we know this more and more every day, right? Public health challenges today are chronic and complex and require joint effort from academic researchers in partnership with clinical and public health practitioners to identify and implement sustainable solutions. And I'll emphasize, in the real world, practice-based research offers researchers and practitioners an underutilized way forward, an opportunity to work together to design and test feasible evidence-based programs to address our greatest challenges. And in my career and role as a practitioner in public health, I've always valued those partnerships with my academic public health colleagues. It's always been win-win between the academic colleagues, the public health practitioners, and the communities or systems that we're working with. And Marcus Plesher at ASTO says, better integrating the science and practice of applied public health will result in more effective and appropriate interventions to scale in states and communities around the nation. That's what we're looking for. How do we take evidence and put it into practice to scale? So just some resources that you have, and we'll share them. I won't go into them all, but some commentaries on IS and practice in Journal of Public Health Management and Practice. A commentary that I did on this topic in the Implementation Science News email site, and podcast with myself and Justin Moore at the Journal of Public Health Management and Practice. After the first Implementation Science Consortium meeting, we reflected on exactly this topic, the role of practice and practitioners. And there's the references from those two articles. Stopping sharing. And what we're going to do now is get into a real case example of this. And let's see, stop the share, and we'll get into a real case example, and then we'll hear from one of our NCI colleagues. So what I will do is introduce our two panelists. I'll do them both now, and we'll kind of segue in a very good practical application example, and then looking at other resources. So Mary Ellen Conn's first, and she's the Assistant Director of Cancer Prevention and Control at the West Virginia University Cancer Institute. She oversees program delivery and implementation of health systems change initiatives and primary care clinics, utilizing evidence-based interventions and implementation science for colorectal cancer screening rate improvement and cervical cancer prevention. She has 25 years of experience in public health, cancer prevention control, partnership development, and community-based participatory research. As a lifelong West Virginian, she is committed to reducing cancer health disparities and providing cancer education and outreach to rural audiences. And she's also the chair-elect of the Cancer Council of the National Association of Chronic Disease Directors. And also, Aubrey Villalobos she's a health scientist with the IS team, Implementation Science team, in the Office of the Director and the Division of Cancer Control and Population Sciences at the National Cancer Institute. And in this role, she leads a number of efforts to advance the involvement of practitioners in IS to enhance the integration of evidence-based guidelines, programs, and policies for cancer control and public health and clinical practice. She cultivates research practice partnerships as the 2021 chair of the Comprehensive Cancer Control National Partnership. And prior to joining NCI, Aubrey served as Director of Cancer Control and Health Equity at the George Washington University Cancer Center, where she supported strategic planning for the center's community outreach and engagement activities and directed a multi-million-dollar portfolio of sponsored projects, providing technical assistance and training to public health and healthcare professionals. And she also has experience working as cancer education outreach at St. Jude's. So both of these people bring great background and experience and really exemplify the exact themes that I was just talking about, which is how to make all this work in real world settings. So with that, we'll turn to Mary Ellen Conn and start with your real world example. Also to note that Mary Ellen Conn and her colleagues' work is featured in IS at a Glance as one of the case stories in there. So thank you, Mary Ellen.
Hey, thank you, Randy. I wanted to thank you all for allowing me to come speak with you today. I'm going to talk with you about some implementation science and practice work that we had done with some of our clinical programs. We are funded by the CDC. We're one of the colorectal cancer control programs. So the work that I'm going to be sharing was work that was done under our program to increase colorectal cancer screening. And really with that program, we partner with health systems to aid them in implementing evidence-based interventions so that they can increase their colorectal cancer screening rate. So in our work with these clinics and health systems, we were primarily focusing on the evidence-based interventions of client reminders, provider assessment and feedback, provider reminders, and reduction of structural barriers. And in working with each of our clinical partners, our goal was to help them increase their colorectal cancer screening rates to the national goal of 80%, or at least 10% over their baseline. And at the end of the 5 years, when we worked with all of these clinics, we actually saw from their baseline to the end of the 5-year period, we really saw a total increase for all of the clinics of over 42% in their screening rate. So we were quite pleased with that. This next slide is just to give you a little bit of a visual as to the reach of the work that we did with the clinics here in West Virginia. Over our 5-year period, we were really set up that we would bring on a new cohort of clinic partners, and we would work with them over an active 2-year period. After that initial 2-year period, they then went into a maintenance and a sustainability phase where they were continuing to do this work on their own. However, our direct involvement and direct support began to lessen. So this map is really illustrating the different cohorts that we had, who made up those cohorts, and where they were located. So when we first started our program, we worked with 6 health systems with a total of 16 clinics. All of them were federally qualified healthcare centers. And when we first started out, we were really targeting counties that were designated as being a colorectal cancer hotspot, meaning that they had higher rates of mortality. As we moved into our 2nd year of our program, we did utilize our community advisory board, and we got some very great feedback from them in that really thinking that we should switch and put our focus and priority on counties that had high rates of late-stage colorectal cancer diagnosis, because we know high rates of that means there's not a lot of screening going on. And in terms of trying to move the needle and see improvement, we felt that could be done a little bit in a more timely manner if we were working in those counties with late stage diagnosis. So in our cohort 2, we brought on 8 clinics. Once again, majority of them were federally qualified healthcare centers, but we've also worked with a community health center as well as a safety net free clinic. And then over the remaining 2 cohorts, in cohorts 3 and cohort 4, we did bring in some primary care clinics through our academic medical center. And then also in year 4, some additional FQHC safety net clinics. And then we also did a pilot with the county health department because in the 5 years prior to that, none of our county health departments had been doing anything with stool-based testing or offering colorectal cancer screening due to budget cuts. And so I said, we really worked with them on a variety of different evidence-based interventions. What I'm going to talk to you about today is an intervention that we did with them under client reminders. And it was really working with them to enhance call reminders that they were making to their patients who were given a FIT test, but yet that FIT test was still outstanding. And this enhanced call reminder program that we developed, we based it on the constructs of stages of change. And it was really incorporating the use of tailored reminder messages when the reminder call was given to the patient, with the hope that that tailored messaging and really trying to motivate the patient to move from one stage to the next, that it would result in a better return rate of their FIT. So the data that I'm going to report on today is really from 9 health systems that were representing 17 clinics. These health systems ranged anywhere from a single clinic up to 5 clinics. And this is data that was collected over a 10 to a 17-month period. And for this intervention, we really worked with the clinic partners, excuse me, to come up with the implementation strategy. So for that, we needed to work with them on developing a workflow for the FIT distribution and the follow-up. We worked with them on identifying staff who would make up to 3 reminder calls for any unreturned FITs. We also did some training with those staff who were making the calls. We trained them on stages of change. We developed an algorithm that they could use when they talked with the patients to very quickly determine where among the continuum of stages of change that patient was in their decision-making process, as well as we developed the tailored messaging for each of those stages. And then we also developed a tracking log for them to use to monitor the follow-up reminder calls, and then also what tailored messages that they gave the patient. And then also this was used for data collection as well. So I'm going to talk a little bit about when you are doing things with implementation. Oftentimes we have what we consider to be the ideal intervention versus the reality of how that intervention was actually implemented. So our original design when we put this together was that we envisioned that the first reminder call would be made within 7 to 10 days of an unreturned fit, and that the clinic would make up to 3 reminder calls using a choice of the tailored messaging based on stages of change. After those 3 calls, if it still had not come back, they would send a letter. We also developed this with the thought in mind that the reminder calls would be made by a nurse or a care coordinator, and that also that they would be doing the actual tracking of the fit. In terms of working with the health systems that we had, we did need to make some adaptations for how each of them carried out the intervention. And it was really based on their capacity and their ability in terms of what the workflow. So what we did see when we did this intervention is that 6 of the 17 clinics were able, or of the health systems were able to do that first reminder after the first 7 to 10 days. 2 of them needed to push that out to 14 days to 2 weeks. And 1 of them actually pushed it out even further from that to 21 days after an unreturned fit. What we also saw with our clinic adaptation is that rather than the 3 calls we envisioned, it really turned out to be more of up to 2 reminder calls, which were then followed by a letter. 1 health system did do 3 reminder calls, but they did no follow-up letter. And then we had another health system that, based on their staffing and workflow, theirs varied greatly in the fact that they didn't start off with phone calls. They mailed a reminder letter first, and then that was followed by a single call if the fit did not come back. And then the reminders, they were really made by a variety of staff, not just nurses and care coordinators, but it was also lab technicians, health coaches, and in some clinics, even front desk staff were making these calls. And while we provided them with the data tracking sheets, we really saw that the tracking varied. In fact, we had more than the 17 clinics that I'm going to present on that actually did do this intervention. And while we did see improvements in their colorectal cancer screening rates, the way in which they tracked the data and monitoring of the return fits, when it came to data analysis, we really weren't able to flush out which ones came back initially on their own versus which ones came back due to the actual reminder intervention itself. And this is just an example of one of the workflows from one of our clinics, and that this is one that they were actually placing 2 reminder calls, and then they would send a letter if the fit did not come back in after the second reminder. And in terms of overall results of when we did this intervention, over 5,000 fits had actually been ordered and disseminated to patients. And the average rate of initial return, those that came back in on their own without prompting of a reminder, was 41.1%. And we saw a range going from a low of 16.1% all the way up to a high of almost 71% of initial return. So of those fits that did not come back in on their own, where a reminder had to be was made and the process was gone through, we saw an average return of those outstanding fits after reminder of 41%. And so looking overall for all of the clinics, the overall average return rate of fits was 60.7%. And that really showed that we had an average increase of 19.6% for the fits that came in after getting a reminder. And when we looked at the data and some of the literature of the studies at that time, this was before the U.S. Preventive Services Task Force had changed their screening recommendations that just happened recently. But based on the literature review that was on that US PTF review of using client reminders for return of fit test, what we saw with those studies is that they were showing about an average increase of 11.5%. And all but one of the clinics that participated in our intervention had return rates that were higher than 11.5%. So we were quite pleased with the outcome of that. And so with this slide, this is just kind of showing each of the health systems and what their results were, looking at initial rate of return, their fit return after the reminder, and then their total. And I wanted to kind of give you a little bit of a tale of two health systems to really look at what their rates were and how the implementation of how they delivered this call reminder had an impact on some of these return rates. So I'm going to start first right here with health system number 3. This was actually a health system that there were 4 clinics that participated in this. And you see they had an initial return rate of almost 71%, much higher than anyone else in the intervention. And so in working with them, we really went back and we looked at their workflow and how they were doing this, because we really wanted to identify, okay, what is different here compared to all the other clinics, so we can identify what is the best practice. The difference in this particular health system, and this is how it was done in all 4 of their sites, is that after the patient met with the provider, agreed to do a fit test, on their way out of the clinic, before they got to the checkout desk, they had to stop by the lab to pick up their fit test. And the lab technicians were actually taking about 5 to 10 minutes to provide education to the patient about the test, how to properly do it, how to return it to them. So we really felt that that extra time that was going into doing a little bit of patient education on the front end, it did have a big payoff in terms of the number of those fits that came back in on their own. Whereas in comparison, if you look at health system number 4, you will see that their fit return rate after the reminders were done was the lowest of any of them. It was only about 15% return after the reminder. And the difference in implementation with this particular health system here is that they did not start with a phone call. Their initial reminder came in the form of a letter. And they were also the outlier in terms of they did not begin their reminder process until 21 days after the fit did not come back in. So much greater time lag before the reminders were even given. And then when they did do the reminders, it was not personal outreach through a call, it was a letter, and then that was followed just by a single call if they did not return the fit. So definitely, it's not just always looking at the numbers of what your returns are, but really looking at trying to correlate what are the differences in the delivery and the impact that it has on the outcomes. And then, of course, these things that we learned, we were able to share as best practices with our other clinic partners as well. As part of our research analysis that we did on this Fit Reminder Call program, we also did a cost analysis. And so we really were looking at the average total cost of the amount of staff time that it took for the tracking, the time to make the calls, cost of mailings if they did the mailings. And we saw that the average total cost for everything was $60.18 per fit returned. When we got that figure, it was kind of, it seemed very high to me. And I was concerned about, okay, where do we fall in terms of comparison to other types of projects that were done in similar populations and clinic sizes as ours. And so we were able to see with some literature review that some other type of similar reminder programs that were done in smaller rural-based health settings had average costs that ranged anywhere from $45 to $74. So we really fell in the midpoint of that in terms of the cost. We do recognize that we did have some limitations with our project and with some of our data analysis. For one, the cost analysis, this was done retrospectively. And so it was just asking the clinics to go back and to estimate the amount of time that it was taking the staff to do this. We also had 2 health systems that had much higher costs compared to the others in the cohort. And that was really due to issues that those particular sites had One had difficulty with tracking due to their electronic health record, a variety of problems that they had had. They actually switched their electronic health record midway through this project. And then another site had difficulty getting outside lab completion reports. So there was a lot of staff time that went into tracking down these type of test results that weren't coming back in. And then the other thing that we saw is that rural clinics with small populations, they are generally going to have higher costs to begin with. And that's really due to low volume and economy of scale. And this chart is just really showing you where things were in terms of the cost per fit return for each of the health systems. So once again, if you look at health system number 3, they were the ones that had the very high rate of initial return. Their cost of tracking and reminders per fit return was about $9, whereas comparison to health system number 4, which had the very low rate of fits coming back in even after reminders, they were the one that had problems with their EHR. They were also having some other problems with tracking. So you can see they were very high in terms of $352, almost $353 per fit returned. So a lot of variables do go into that in terms of what those overall costs may be. And in terms of lessons learned, what did we walk away with this? And what were we able to share with others who are doing this type of work? And so one of the lessons is definitely that timing matters. The timing of the reminders, definitely those sites that started placing the reminders much earlier in the process had a better outcome compared to the clinics who had a much later date of when they actually started the reminder process. And then that mode of initial contact also plays a big difference. We saw that, placing the calls, actually making that human connection, that touch point with a patient by phone call, by conversation, definitely had more of an impact than receiving a reminder via a letter. The other thing is that we often joke about with our work and working with a lot of clinics and a variety of EHRs is that your electronic health record system, it can either make or break your intervention. And so we definitely saw that. We saw that those sites who had been using their EHR for a longer period of time, much more stable process with the EHR, that the tracking and this went much more smoothly compared to the sites that were having difficulty and that their EHR wasn't capturing the information that they needed, or in terms of if they actually switched their electronic health record program midpoint through. We also saw that the calls can really be made by a variety of staff. The lab technicians, the front desk staff, all of these individuals, for many of them, they do have a touch point at some point in the patient flow of coming in for an office visit. And so it didn't always necessarily have to be a nurse or a care coordinator, that other staff could pick up and take on these roles to help in making the reminders. And we also saw that one of the things that making the reminder and talking with the patient, and especially working with them and identifying where they were within the realm of stage of change and giving specific tailored messaging, is that follow-up contact. It gave some additional opportunity to address barriers to screening that the patient may not have disclosed or talked about with their provider while they were there for their visit. And also those follow-up contact calls also provided an opportunity to provide some further education if the patients needed it. And then as far as the challenges that we saw, problems that ran into, trying to make this type of intervention work, updating the clinic workflow to integrate the reminder protocol was a challenge for some of our clinical partners. Some had concern about duplication of tracking on the spreadsheet log compared to what they were doing with their electronic health record. And I will say that while some of the clinics felt it was a little bit of a burden to do this external spreadsheet tracking, we did have one site where that spreadsheet really did help them in the end. They were one that did switch their electronic health record. And as they worked with that new EHR system, it became very clear it was not doing as good of a job on the tracking of fits as it did in the old system that they had. So having that external log of the ones that had been disseminated versus the ones that had come back in did help them out in their reporting in the long run. We also saw there was a lot of inconsistent tracking and data collection. And so, as I said, we did have to drop some of the clinics from our overall data analysis. And then another challenge, and this is not just to this intervention, but often with any type of intervention that's done in clinical settings, staff turnover happens, there's need for retraining. And then finally, despite efforts to reach out and to remind the patients and reach out to them, there are some patients that they just simply do not complete screening, regardless of the attempts that you have made to work with them. And so I just want to acknowledge our health system partners that worked with us and that I reported the data on, as well as our collaborators from CDC and RTI International and the great staff that I have working here with me. And so I wasn't sure, Daniela and Randy, are we doing questions now or are we holding those till the very end?
Excellent. Thank you so much, Mary Ellen. That really excellent. I have lots of questions and I think our other scholars do too. This was really interesting. I thought maybe we could go to our next presentation and then we can have some discussion and Q&A at the end. How does that sound?
Sounds good. So we don't short shrift Aubrey.
Excellent. Okay.
Take it away, Aubrey.
I'll try and be efficient and I'll just let Sam bring up my slides. So thanks everyone for the invitation to speak today. It's exciting to be here with you. Next slide, please, Sam. So I just want to start off by noting that there's been tremendous progress in cancer research in the 50 years since the National Cancer Act was signed and really accelerated cancer research focus and funding, but there's still so much more work to be done. And so I'm going to talk about linking research and practice and share some resources and initiatives at the NCI to support that work. Next slide, please. So I want to start off by sharing what I hope is a new angle for you on implementation science and practice, and that is thinking about just whose role it is to link research and practice. Next slide. There's a nascent but growing body of research and thinking around a distinct professional role in implementation support practitioners. Allison Metz and Bianca Albers and their colleagues have led the research I'm going to quickly share today. They suggest conceptualizing implementation support practitioners as professionals who are not involved in direct service delivery or management. Instead, they work closely with leadership and staff needed to effectively deliver direct clinical, public health, or social services to individuals, families, or communities, and they support them in implementing evidence-informed practices, policies, and programs, and in sustaining and scaling that evidence for having a population impact. They may be referred to by many other names, as you can see here, but these are individuals who, through the use of unique combinations of knowledge, skills, and attitudes tailored to the contextual settings in which they work, they can really help individuals, agencies, and service systems to effectively use evidence-based and research-supported interventions, maintain their use, and generate positive implementation, service, and client and health outcomes. Next slide, please. So Metz and their colleagues have proposed a set of competencies that are critical to successful implementation support. And these fall into the domains of co-creation, ongoing improvement, and sustaining change. And so I'm hoping that some of you may see yourselves reflected here. Next slide, please. In a recently published integrative review, the authors analyzed implementation strategies employed by implementation support practitioners as a means or methods for adopting and sustaining interventions. The strategies shown here and on the next slide were the most commonly used and described in 10 or more of the nearly 100 studies they reviewed across diverse practice settings. It's important to note that implementation support practitioners typically use multiple strategies, on average 4.5 different ones in any given implementation effort, and that ranged from 2 to 9 different strategies. The common strategies included approaches to train and educate the different participants or stakeholders, conduct assessments and evaluation for iterative practice improvements. Next slide, please. Strategies for building interpersonal relationships and tailoring implementation strategies to context and promoting adapting interventions to context. Two strategies that are not found within the ERIC compendium that I believe Dr. Sarah Birkin mentioned in your last webinar included sourcing, sharing, and translating evidence of relevance to stakeholders, and contributing to intervention design to better design for dissemination and implementation. You can find more about the other lesser reported strategies for implementation support in the full article, but I just wanted to share some of those with you. Next slide, please. So the common strategies they uncovered really imply some core skills and tie back to the proposed competency model. And these included data collection methods to assess the needs, preferences, and resources, and also for monitoring and evaluation, planning and operationalization skills, and being able to kind of use multiple implementation strategies and integrate them, kind of general project and group management, teaching and training skills through various methods, relationship building, trust building, and kind of weaving networks and connecting people, being neutral in situations, being able to develop and employ social capital in a community, and having cultural humility, troubleshooting, competent consumption of research and theory, integrating multiple perspectives and building consensus. And I'm sure there are many others, but these were some of the key skills. So some things to take away from this emerging area of research, no matter what your professional plans after the Scholars Program ends, is how can we build capacity for these strategies and skills among the existing workforce, as well as students coming through the pipeline. There are also a variety of ripe research questions posed by Metz and Albers that are worth investigating if we are to move toward effective, equitable, scalable, and sustainable implementation practice. Next slide, please. Oh, you're on there. Okay. So now I'm going to share a few existing initiatives from the NCI and other organizations that might be of interest in your work to link implementation and practice. Next slide. Thank you so much, Sam. I'll first remind you of one of your recommended readings for the Scholars Program. So designed specifically for cancer control practitioners, and as Randy mentioned, Implementation Science at a Glance provides a succinct overview of this rapidly evolving field. The workbook was written by members of NCI's IS team and reviewed by public health practitioners and implementation researchers. It includes summaries of key theories, methods, and models, and shows how the use of implementation science can support effective adoption of evidence-based interventions in practice. And it includes several case studies to illustrate how practitioners are successfully applying IS in their cancer control programs, including Mary Ellen's example that she shared with you earlier. So please feel free to distribute this with your networks. Next slide, thank you. The recently updated Training Institute for Dissemination and Implementation Research in Cancer was also an optional learning component of your Scholars Program. And there, I want you to know we have both a facilitated annual training with mentorship designed for researchers, as well as an open access set of modules that can provide advanced training in some of the key theoretical and methodological foundations of the field. There are brief emerging issues topics as part of the recorded content, and we're planning new modules for the future on additional emerging topics. Next slide, please. Coming in 2022 from the George Washington University Cancer Center, Implementation Science Base Camp is a training for practitioners in cancer control designed to help them optimize the implementation of evidence-based interventions. This training is being developed for teams of cancer control coalition representatives, program directors from health departments, clinical and public health champions, executive leadership, from community-based organizations, and it's going to cover over 20 competencies to provide a foundation in this field centered around assessing context, using evidence and theories, evaluation, facilitating implementation, so that implementation support role, and sustainability. And they're going to include case studies as well, and participants who go through the training will leave with a team-created implementation blueprint that can serve as kind of a logic model or a program plan for future work, or it can be used to kind of really retrofit existing programs along implementation science guidelines for that quality improvement. Next slide, please. The Evidence-Based Cancer Control Programs website that Randy mentioned, formerly RTIPS, is a searchable database of cancer control programs and related implementation materials. This site is designed to provide program planners and practitioners with easy, immediate access to evidence-based materials. Next slide. The website provides a review of programs available for use in community or clinical settings. There are currently over 200 programs available on the website across a range of health topics, delivery settings, and priority populations. Next slide, please. A new feature in 2021 is the monthly release of case studies. This has a build if you'll just click. Thank you so much. Yeah. These have like real world implementation case studies that provide more information about how the programs were adapted and implemented in practice. Next slide. I'm also excited to share a brand new resource that may also be of use to you, whether you fall more on the research or practice side of implementation. Dissemination and implementation researchers and practitioners should purposefully integrate community engagement into their work as a way to speed translation of knowledge to practice and improve health equity. This document includes readings, trainings, guidance, tools, and resources to facilitate researchers and community members in their efforts to practice meaningful community-engaged implementation science. And this is currently under review by the steering committee for the CCIS that Randy mentioned, and will be disseminated through the CPCRN listserv and many other platforms as soon as it's released publicly. Next slide, please. So finally, I just want to talk a bit about partnerships and networks that can advance this research practice linkage. Next. As you likely recall, in early 2016, President Obama called on Vice President Biden to lead a new national Moonshot initiative to eliminate cancer as we know it. NCI convened a blue ribbon panel whose report identified 10 transformative recommendations for achieving that goal of making a decade's worth of progress in cancer prevention, diagnosis, and treatment in just 5 years. Implementation science was a key component of the recommendation to expand the use of proven cancer prevention and early detection strategies to reduce cancer risk and health disparities. And so I think some of the increases in implementation science funding and interest and just the burst in the field has partly been spurred by the Moonshot. Next. Here are the 3 main Moonshot funded implementation science initiatives. And I want to highlight the 7 Implementation Science Centers in Cancer Control, or ISC3, which supports the development, testing, and refinement of innovative approaches to implement evidence-based cancer control interventions. All the centers feature implementation laboratories, which involve clinical and community sites, and they're truly conducting research at the intersection with practice. And so there are opportunities for you to engage with those 7 funded sites if that's of interest. Next slide. Practice-based research networks are another great infrastructure for implementation science. Most PBRNs are groups of primary care clinicians and practices working together to answer community-based healthcare questions and translate research findings into common practice, though some networks are condition or disease specific. PBRNs engage clinicians in quality improvement activities and just building an evidence-based culture in primary care practice. As of last summer, there were 185 PBRNs registered with ARC's Resource Center, and you can kind of see here on the map where they're located. These networks represent practices from all 50 states and over 25 countries. ARC provides infrastructure and technical support for the networks, including, for example, a resource to facilitate the expansion of business relationships between the networks and outside organizations like accountable care organizations, public health departments, and other health-related entities. So this is really kind of a multi-sectoral opportunity for research and practice. Next slide, please. The Association of Community Cancer Centers has also established a Community Oncology Research Institute to build on its mission to close the gap in cancer research through oncology partnerships. ACORI will work to establish clinical trials as a standard of care and treatment plans in community settings. And they're really trying to reach equitable care for all patients. They also plan to include quality improvement and implementation science in their research portfolio as ACORI grows. Next, please. Thank you. It's harder to find public health practice-based research networks than clinically focused networks. And this is kind of historically, there's just been less funding and less of an emphasis on quality improvement cycles in the public health context. But there have been some examples, and some may be still active today. They're just harder to locate. But one network we have really tried to encourage cancer centers to engage with for dissemination and implementation is cancer control coalitions. You're hopefully already familiar with CDC's National Comp Cancer Program, which has provided funding and guidance and technical assistance for programs for the last 20 years to really design and implement cancer control plans. And these plans really identify how the coalition addresses the burden of cancer in that state or tribe or territorial region. And they're evidence-based plans. They include strategies that are evidence-based and are really a blueprint for action and are ripe for implementation research opportunities and the application of implementation science to the practice. All 50 states, DC, 6 Pacific Island jurisdictions in Puerto Rico, and 8 tribes or tribal organizations have produced a total of 63 plans. So there's lots of opportunities there. And the Comprehensive Cancer Control National Partnership is a group of 19 leading cancer organizations that kind of pool our resources and influence to help strengthen cancer control efforts across the nation and help cancer coalitions develop and sustain implementation of the plans. And so as current chair of the partnership, I have to strongly encourage you to look up and get involved in your local coalition if you're not already, because it's a great opportunity for professional development, networking, research, and practice opportunities. Next. Cancer centers are often members of their coalitions, and there are 71 NCI designated cancer centers located in 36 states and the District of Columbia. And community outreach and engagement has been a fundamental activity since the initiation of the Cancer Centers program in 1971, but now there's an increasing emphasis given to COE. Working with community stakeholders, cancer centers have to identify community needs, communicate those needs across the center and their research program, and really catalyze activities of relevance to that catchment area of their patient population. Cancer centers are encouraged to generate examples of research projects where outreach and engagement with communities has informed and resulted in high impact science. And centers are expected to work with communities to disseminate and implement evidence-based interventions, guidelines, public education, and public health policy recommendations. So NCI has funded in the past and plans to fund future supplemental awards to select cancer centers to really support the development of more implementation science tied to community outreach and engagement. Next, thank you. I'd like to invite you to the Consortium for Cancer Implementation Science. It's an annual working meeting that focuses on cancer control priorities, cross collaboration, and innovative solutions in implementation science. NCI is related to this initiative. We are accepting applications for personal service contracts right now from individuals who are willing to dedicate time to develop and deliver specific tools and resources that have been prioritized by some of the action groups of the consortium. You can register for the upcoming meeting and view the outcomes from past meetings to learn more. Our 2021 meeting is going to focus on lessons learned in implementation science from COVID-19. And also kind of re-emerging and moving forward from the pandemic, kind of how do we come back? The event is going to feature a variety of presentations and discussion sessions, as well as pre-work to encourage more engagement and discussion. So please sign up for that. My last 3 slides, I'll just leave you with opportunities for how to connect with our implementation science team. And I'm going to just say thank you and stop there.
Great. Thank you, Aubrey. Thank you, Mary Ellen. Great presentations. And, lots of, as we talked about, real world applications. So we talked about questions. We just have a few minutes. And Daniela, you said you had some, but shall we get some from any of the other attendees?
That sounds great. Let's open it up.
Open it up and
Excellent,
join in with
excellent.
audio and video if you can. And
Mhm.
Maybe I can throw out one. Aubrey talked about great networks. Are you got some of you situated in cancer centers or other networks? Who have you engaged with, just to kind of see what people are doing? Because this is about practice.
So that's not a question to me, Com, right? That's to the scholars. Okay.
Yes.
Yeah, I'd love to hear
I'm
that
trying
too.
to extend what you were enticing. them
Yes,
to.
that would be
Yes.
great.
Is anybody working with cancer centers on small projects, whether it's research or practice-based or some of the other networks, comprehensive cancer, I shouldn't use abbreviations.
I see some shaking heads, but I think everyone's going to click on the map to find the center near them so they can learn more and then reach out to Aubrey to see how else to get involved. Those are excellent links that you shared too.
Right. Daniela, did you want to jump in?
Sure, absolutely. Thank you, Randy and Mary Ellen and Aubrey. Excellent presentations and really great focus on practice for our scholars. I think was really important. My questions for Mary Ellen to start, you had listed some excellent lessons learned from the clinics and the implementation and challenges. And I'm wondering, the way you listed the challenges were there any that really rose to the top, or were they all, similar, were some more prominent than others with the challenges? I was just thinking, like, did the staff turnover, was that the biggest challenge, or was it, others? Were you able to kind of piece that apart from the data that you had? I thought that might be interesting for scholars to see which of those challenges kind of emerge most often when we're talking about this kind of implementation, and then thinking about like linking it with the lessons learned. That would be really interesting.
Definitely staffing issues was something that we did see across the board for all the health systems that did participate. And we knew that going into this, having done work with health systems and clinics before on other types of projects, we often knew that was, it's not unusual to have to go back sometimes once, twice during the life of a project to come in, do some retraining of the new staff. So that was the one that was most commonly seen for all of them. Some of the others that I had listed tended to be a little bit more isolated incidences, especially those situations involving electronic health records. But the two most common were the staffing, and then the concerns that were voiced to us about feeling that it was extra work or double tracking because they were keeping record in their EHR as well as also the external log. The only problem with electronic health records is that, especially for FIT, it's very difficult to track the number, the ones that are given out, because generally they don't enter the order for a FIT until the FIT actually comes back in. So currently, with our funded colorectal program, CDC is asking us for our clinics to report FITs disseminated and FITs returned. And the way that we're having to work with some of our clinic partners is we've developed tracking in REDCap for them to do, because they just simply can't do it within their EHR system.
That's great, very helpful. I see a question from Radhika in the chat here. Was there any language barriers in understanding the usage of FIT? So another question for you, Mary Ellen. Good question.
With the population that we have here in our rural areas, English is the predominant language, so we did not see a problem with that. Currently, this is a new clinic that we're working with. It's a safety net free clinic. So that particular clinic, we are having to work with them to translate things into Spanish.
Great. Thank you.
Aubrey, I had a quick question about the Association of Community Cancer Center. I do feel like that's one of the networks that even CPCRN hasn't really engaged with and things like that. Do you know if they are present at certain things, or should we engage in different ways? Because of all of the ones that you presented, I kind of feel like that one is a little bit more maybe new or newer to the scene.
Yes, I'm sorry. I hope you can't hear the trash truck just pulled up outside of my house. So yes, ACORI is brand new. It's just getting off the ground. So the Association of Community Cancer Centers, ACCC, has been around for a long time, supporting community cancer centers. But ACORI is an initiative. It's actually came out of a partnership between ASCO and ACCC. So ASCO is the American Society of Clinical Oncology, I think. And then so ACCC represents the community cancer centers, and they're trying to work together to really bring clinical trial access to community cancer care. And that was a priority of ACCC's past president, who works, at Lancaster General, so a community cancer center, but it's affiliated with Penn Medicine, and so they get access to clinical trials, and so really trying to make that available. But they're starting with clinical trial access, building infrastructure in community sites to be able to, have trials, participate in trials, refer patients to trials, improve diversity and inclusion in trial recruitment. And then they will also really begin to expand in building capacity in the community cancer sites for quality improvement science and implementation science, and kind of dissemination, implementation, research in those community cancer sites. So that's kind of like coming down on the horizon for them. And I think it's predominantly funded by ASCO's Foundation Cancer Care.
Great.
I had a question. I know it's a little bit over time, but I had a quick question for Mary Ellen and the research that she's doing. We're doing a little bit of research kind of similar, looking at health or survivorship and healthcare delivery. And I was just wondering, you talked a little bit about understaffing. Is it common to have staff members who are cancer survivors have to go back into cancer treatment, like they have cancer again, have to go back into treatment, and then are no longer able to work for that treatment time? I'm just wondering how common that is.
That's a great question. The work that we were doing out in rural primary care, we've not encountered that situation of staff who are cancer patients either actively undergoing treatment or who have needed to go back into treatment. So I wish I had a response for you on that, but unfortunately I don't.
That's
Well,
an
thank you.
interesting question. Interesting question.
Great.
All right.
Well, thank you. Thanks for hosting this great presentation, and thanks to our presenters. And really glad the scholars could get to hear this.
Absolutely. I hope it's okay, Randy, Mary Ellen, and Aubrey, if our scholars have any follow-up questions based on the readings and the resources that they have, as well as today's presentation, if they can follow up with you.
Yes, please do. And please share the
Absolutely.
slides. Yeah.
Great.
Excellent. Thank you for sharing
thanks.
your expertise, and we will be in touch with everyone soon. Thank you. Thank you.
Thank you.
Bye-bye.